My name is Robert Lerrigo. I am a gastroenterologist, just graduated fellowship from Stanford, and I have a special interest in inflammatory bowel disease.
So our next question is also coming from a social media follower, and this is from Naomi. And Naomi asks, is there a point in IBD care when you no longer expect the patient to get significantly better? And if so, do you tell them?
Yeah, I mean, obviously with any disease process that's going on, a physician is obligated to tell the patient what they're thinking of and be honest and forward with regard to either the prognosis or what the next stage is. And to reword the question, I think it really should be worded, is there a point in IBD care when patients are no longer benefiting from medical therapy? There's always something physicians can do to patients. You know, there's the medical therapy, which are kind of the pills or the injections that we give them, and then there's surgical therapy. So we like to try out medical therapy first because a lot of patients can benefit from that and can stave off surgery. But there's been not a new way, but an emerging way of thinking of IBD is we as in patients and physicians shouldn't be thinking of surgery as a failure on the part of patients or a failure on the part of medical therapies. Some patients, because of how severe their disease is, their disease course is just heading towards surgery regardless of what medicines that they're being given. So just to give you an idea, so for Crohn's disease, the 10-year cumulative risk of major abdominal surgery is 40 to 55%. This is before biologics. And now with the new biologic drugs that we give, biologics being like Humira, like Remicade, things like that, this has gone down to about 30%. So that's still pretty high, like 1 in 3 patients over 10 years with Crohn's disease are at risk of developing or requiring a major abdominal surgery. If you've had one surgery, your 10-year risk of requiring another surgery is about 35% or so. With ulcerative colitis, slightly less. So 20 to 30% of advanced ulcerative colitis patients eventually require abdominal surgery during their lifetime. So it's sometimes just the natural progression of the disease. Again, as we develop some new therapies and better therapies, I expect that the number of patients requiring surgery will go down.
So I actually do have a follow-up question for you on this. If the patient has had surgery, does your answer change at all?
If they've had surgery before, again, with things like Crohn's disease, particularly Crohn's disease, because they can develop strictures elsewhere, they can develop complications, long-term complications of the surgery itself. I always tell them that there is a risk of requiring another resection. And again, I quote them the 35%. So over 10 years, the risk of requiring another surgery after your first is about 35%. So about a third of patients require a second surgery. And then I have a discussion about things to be mindful of, symptoms to be mindful of after a surgery, to make sure that they don't develop those chronic complications, or at least to make sure that we're aware of them early.